Be talking about cervical ripening in pregnancy. This is the ACOG Clinical Practice Guideline number 9, which was released in July 2025, which replaces the Practice Bulletin number 107, August 2009. So, what this lecture will consist is first epidemiology and background, then definition and Bishop score. Then we'll have indications and contraindications, then overview of the methods. Then we'll see all the recommendations at glance, and then we'll see misoprostol. Then we'll see dinoproston, what the ACOG guideline says about balloon catheter, and then combination methods, and about outpatient cervical ripening, comparison summary table of all the ripening methods, and then high yield exam points. So we'll first come on to epidemiology and background. Now since this is ACOG, this is mostly data from USA. So remember that. So it won't be so important from exam point of view since this is data based on USA, but it's good to know about all of this. So 31.9% of births involved labor induction in USA. This is according to the 2022 data, and 84% of induced patients required cervical ripening. But there was a 42% rise in elective inductions after the ARRIVE trial. Now, what is the ARRIVE trial? As per the ARRIVE trial, IOL should be done at 39 to 39 plus 4 weeks in low risk nulliparas. If it is done at that time, it decreases cesarean section rates and it also decreases hypertension disorders. But induction is associated with longer labor and delivery stay. Normal is 20 hours versus, so median 20 hours versus 14 hours in expectant groups. So let's talk about the Bishop score and definitions. So as per ACOG 2025, it is still using the old Bishop score, not the modified Bishop score. Remember that, because the modified Bishop score uses cervical length instead of effacement, and that is something that you can see on ultrasound. So it still requires the Bishop scoring system, not the modified, because the Bishop scoring system is clinical. You don't need, and it's a good bedside tool. So for dilatation, 0 is given for closed, 1 to 2. So you can remember score of 1, then 1 plus 2 is 3, then 2 to 3 to 4, and then 3 is 5 to 6. So you can remember 2 ka double is 4 and 3's double is 6. So you can remember the scoring like this. Then position of cervix, 0 is posterior, mid position and anterior. 1 is given for mid position and 2 is given for anterior. Then we have effacement, 0 for 0 to 30%, 1 is for 40 to 50%, 2 is for 60 to 70%, and 3 is for 80%. Then again a score of 0 is given for -3, 1 is given for -2 station, and then 2 is given for -1 to 0, and a score of 3 is given for +1 to +2. A score of 0 for firm cervix consistency, score of 1 is given for medium, and a score of 2 is given for soft. So position of cervix and consistency don't have anything for 3. They just have a scoring from 0 to 2. So originally it was developed in 1964, most widely used method to reassess the readiness of the cervix for labor. Thresholds of 3 to 8 used to define unfavorable cervix needing ripening before oxytocin. Parity and gestational duration also affect the IOL course, and hence it is integrated into clinical decision making. So it is basically saying that the parity, there'll be a difference in the same score. Suppose a nulliparous with a score of 3 and a multipara with a score of 3, both of them will have different response to cervical ripening agents. Indications and contraindications. So indications, clinical criteria for IOL is met with unfavorable cervix. So clinical criteria is in only patients with high risk, like patients with hypertensive disorders, patients with GDM or diabetes, patients with FGR without Doppler changes, so things like that. Most studies are done on term, singleton, vertex, intact membranes. Parity, gestational age also guide decision. Patient counseling on methods plus benefits, and risk is required. We have to tell them about the tachysystole risk, more than 5 contractions in 10 minutes, and a 30-minute average is taken. Maternal and neonatal infection monitoring is required. Longer labor and delivery stay, so patients must be educated. Now, contraindications, misoprostol and prostaglandins are contraindicated in any prior uterine surgery, including cesarean section. Allergy or sensitivity to the cervical ripening agent, prior cesarean section or uterine scar, mechanical methods or oxytocin only is used. No universally accepted definition of unfavorable cervix. Now, there is no racial or ethnic differences in use of cervical ripening agents. Now we go on to the overview of cervical ripening methods. So categories. Pharmacological is misoprostol, which is a PGE1. So first is misoprostol, which is PGE1. PGE1. And then second is dinoproston, which is PGE2. Mifepristone is antiprogesterone, a less effective alone, useful adjunct. Then mechanical, first is Foley's. It can be single balloon catheter or double balloon catheter, or they can be osmotic or hygroscopic dilators like laminaria or Dilapan S. Combination methods are balloon plus misoprostol, balloon plus oxytocin. This is safe in uterine scar, previous uterine scar. Balloon plus misoprostol is not safe in uterine scar. Balloon plus dinoproston is not safe in uterine scar. Then mechanism of cervical ripening. So what pharmacological methods do is that they increase the collagenase activity, which leads to breakdown of the cervical collagen bundles. They stimulate release of cytokines IL-8, hyaluronic acid, elastase, which increases the effacement. So misoprostol is oral or vaginal. Sublingual is now not recommended. Currently available as 100 microgram tablet, and you can divide the 100 microgram tablet. Then we have dinoproston PGE2 gel 0.5 mg in a 2.5 ml syringe or vaginal insert, which is 10 milligram. Then mechanical. Now these direct mechanical pressure on the cervix, which releases local prostaglandin release, which stimulates the stretch receptors. Single balloon Foley's is placed above the internal os. So if this is the external os, this is the internal os. So the balloon is placed above the internal os. And in a double balloon, if this is the internal os and this is the external os, so one is placed above the internal os and one is placed in the vaginal fornix outside the external os. Then osmotic dilators, these absorb water, swell, circumferential pressure, and that leads to prostaglandin release. They can be placed with or without speculum. Speculum is not required for digital Foley's insertion. So all recommendations at a glance. So summary of all the ACOG recommendations is that first, which is a strong high quality recommendation, is use pharmacological, mechanical or combination methods for cervical ripening. This is a high quality evidence. Now conditional high quality is that use pharmacological plus mechanical combination to shorten time from admission to delivery in appropriate candidates. Strong high quality evidence is that use oral or vaginal misoprostol for cervical ripening. Strong moderate quality evidence is vaginal dinoprost can be used for cervical ripening. Strong high quality evidence is mechanical methods of cervical ripening should be used. Conditional high quality reference is outpatient cervical ripening is safe and effective to reduce time from admission to delivery in low risk patient. Now what does this mean? Now strong evidence means that the benefits are overweigh the harm most patients should receive. Conditional is that balance of benefits or risks varies. Individualized decision making recommended. Shared decision making is recommended. So we go on to pharmacological method, that is misoprostol. So misoprostol is PGE1. We can give it oral, vaginal, sublingual or buccal. Now they don't recommend sublingual anymore for cervical ripening. A 100 microgram tablet can be either you divide it into 4 parts for 25 or you divide it into 2 parts for 50 microgram. Contraindicated in prior uterine surgery like cesarean section myomectomy because there is risk of uterine rupture. Allergy to misoprostol. Then we have sublingual or buccal routes not recommended for routine use. So sublingual, highest peak serum levels, rapid absorption. But it increases tachysystole risk according to the meta-analysis of 5 trials. So buccal versus vaginal. So vaginal 8 hours shorter time to delivery, higher vaginal delivery within 24 hours. So dosing, vaginal 25 microgram is preferred. So 25 microgram in vaginal is preferred, or you can use 50 microgram. You have to give it every 3 to 6 hours. Now 25 microgram is safer, there is less tachysystole. 50 is faster delivery but increased tachysystole. 50 you can consider in where will you consider 50? You will consider 50, you will consider 50 in multipara or more than 30 BMI. So oral static dosing has to be given. 25 microgram is preferred. If you are giving it 25 microgram, you have to give it 2 hourly. If you are giving 550 to 100, you have to give 4 hourly. So static is preferred over titrated. So you give the same dose instead of titrating the dose. It has the same efficacy, fewer side effects, less cesarean section and less tachysystole. Half-life is 20 to 40 minutes. So dose, it is important that you keep the dose the same than the frequency than titrating it. Sublingual is not recommended because it increases tachysystole. So you have to do a trauma-informed approach. Consider oral misoprostol when patient is uncomfortable with multiple vaginal exams. Vaginal versus oral. Vaginal leads to more vaginal births in 24 hours. It is 60.8% versus 49.3%. Oral causes less tachysystole with FHR disturbances. So now oral versus vaginal misoprostol, what does the evidence say? As per Cochrane 2021, oral less than 50 microgram versus vaginal. So oral leads to fewer vaginal births in 24 hours. Oral leads to less tachysystole though with FHR disturbances. There was no difference in overall cesarean section rate. Oral leads to lower cesarean section for fetal distress. 10 to 25 microgram oral leads to less tachysystole. 50 microgram oral, same as vaginal for tachysystole. As per RCT done in 2024, vaginal 25 versus 3 hourly versus oral 100 microgram 4 hourly. Vaginal delivery rate is similar. Mean time to delivery is 19.7 hours in both groups. Tachysystole with FHR is less frequent with vaginal. Vaginal reduced oxytocin use, benefit when nursing staff is limited. NICU admission slightly higher in the vaginal group. Neonatal outcomes overall not different. Then 25 microgram versus 50 microgram vaginal. 50 microgram more delivery after the first dose. Higher vaginal delivery in 24 hours. Less oxytocin is needed. 50 microgram worse safety, more tachysystole, more cesarean section for non-reassuring FHR, more NICU, more meconium. 25 microgram preferred except selected cases where I've told you in multipara and in BMI more than equal to 30. So let's talk about dinoproston now. So dinoproston is PGE2. It is contraindicated in previous uterine scar. Vaginal gel is 2.5 ml syringe in which there is 0.5 mg dinoprostol. It is placed in the cervical canal where intracervical below the internal os. So 0.5 mg you have to give 6 hourly, maximum 3 doses. 1.5 mg can be given in 24 hours. There's an insert also, 10 mg. It is placed in the vaginal fornix and stays up to 12 hours. So vaginal versus intracervical dinoproston. Vaginal is more effective than intracervical. Intracervical increases risk of not achieving vaginal delivery in 24 hours. As per recent RCT, vaginal causes shorter induction to delivery, 15 hours versus 28 hours, higher vaginal delivery in 24 hours, 63.3% versus 40.6%. Then dinoproston versus misoprostol. So vaginal misoprostol is better than dinoproston, lower failure to vaginal delivery in 24 hours, less oxytocin augmentation. As per individual participant meta-analysis data, low-dose vaginal misoprostol is equivalent to dinoproston for vaginal delivery, but misoprostol lower composite adverse maternal outcomes. Dinoproston disadvantage, it is more expensive and also it requires refrigeration. So let's talk about the balloon catheter. So efficacy and safety. Overall evidence, balloon is similar to vaginal dinoproston and misoprostol for cesarean rate and vaginal delivery within 24 hours. More favorable safety profile, less uterine hyperstimulation with FHR disturbances versus oral misoprostol. Trend is to decrease vaginal delivery but also decrease composite adverse perinatal outcomes. Now osmotic dilators versus dinoproston, there are comparable maternal and neonatal outcomes. Lower risk of hyperstimulation in osmotic dilator group. Some studies show higher patient satisfaction with osmotic dilators. Mechanism: direct mechanical pressure on the cervix stimulates local prostaglandin release and inflammation. Circumferential pressure osmotic dilators, or balloon pressure like in Foley's. Balloon catheter practical management points. Now, single versus double balloon. Double balloon is more costly and there is no proven superiority in vaginal delivery rate or time to delivery. A single Foley's catheter is standard and sufficient. Placement technique: digital placement versus speculum. Digital has similar failure rates, similar placement time, better patient satisfaction and preference. Either technique is acceptable. Duration of balloon placement: 6 hours versus 12 hours. So there's no clear advantage of keeping the balloon more than 6 hours. Many combination studies kept the balloon up to 12 hours, both durations used locally. So inflation volume: 30 ml to 80 ml studied. Volumes more than 30 ml, shorter interval to delivery. CS rates are similar, higher volume but causes more patient discomfort. So traction: application of traction to the catheter, no effect on clinical outcomes including time to delivery. Then let's talk about combination methods. So the evidence on combination methods: best evidence is Foley's balloon 30 ml plus vaginal misoprostol 25 microgram. In a network meta-analysis, it was the most effective and safest strategy overall. Decreased NICU admission, decreased tachysystole, decreased operative vaginal delivery, decreased low APGAR scores, lowest odds of cesarean section and highest odds of vaginal delivery in 24 hours. But the limitation of this evidence is we cannot assess the chorioamnitis risk, cannot assess quality of all included studies, and cannot examine effect modifiers like parity, gestational age, indication, BMI, cervical status, labor management. Other meta-analysis and RCT also support misoprostol-based regimens superior to single methods. Mechanical plus any pharmacological option like misoprostol, oxytocin, dinoproston is better than a single method, particularly shorter time to vaginal delivery. But remember that misoprostol plus balloon both are contraindicated in patients with uterine scar. Balloon plus oxytocin can be used for patients with prior uterine scar. So outpatient cervical ripening is something that this guideline talks about. So what is the evidence for it? So strongest evidence for dinoproston or single balloon in outpatient setting. Evidence most generalized to age 25 to 30 years. No major comorbidities, mostly nulliparous 65%, mostly post-term induction 61%. There was no increase in cesarean section, infection, PPH, meconium aspiration, birth trauma or shoulder dystocia. Outcomes are generally similar to same interventions inpatient. Now pharmacological outpatient. Vaginal misoprostol 25 microgram was the most effective, decreased time to vaginal delivery. There was no change in CS odds, no additional ripening required, no increased perinatal outcome. Synthetic osmotic dilators decreased hospital length of stay without significant adverse outcome. Key eligibility required. There was no indication for maternal or fetal monitoring during cervical ripening period. Mandatory inclusion criteria in all. This is a mandatory inclusion criteria in all outpatient studies. Now, where are the evidence gaps in this? Optimal fetal assessment mode in outpatient protocol not identified. Characteristics of patients who benefit the most or have the lowest risk is not defined. So let's have a comparison summary of all the cervical ripening methods. So vaginal misoprostol is considered efficacy is good, safety is better than 25 microgram. In scarred uterus it is contraindicated. It is first line, reduces oxytocin need. Then vaginal misoprostol 50 microgram, higher vaginal delivery in 24 hours, but it increases tachysystole, contraindicated in scarred uterus. We should use it selectively for multiparas and BMI more than 30. So this should be used for multipara and BMI more than 30. Vaginal 50 microgram. Otherwise, you can use vaginal misoprostol 25 microgram. Oral 25 too early. It is efficacy is slightly less than vaginal, but there is less tachysystole. Contraindicated in scarred uterus. It is the preferred oral dose. Static dose is better than titrated dose. Then oral misoprostol 100 microgram 4 hourly. Similar vaginal delivery rate, but it increases tachysystole. So, and it is contraindicated in scarred uterus. More tachysystole at a higher dose. Then vaginal dinoproston. Efficacy is lower than misoprostol. Safety is similar to misoprostol. It is contraindicated in scarred uterus, more expensive and needs refrigeration. Single balloon Foley method, similar to efficacy is similar to pharmacological. It is best in safety terms because least hyperstimulation. It is safe for scarred uterus. Digital placement is preferred, 30 to 80 ml, no advantage to tension. Then balloon plus meso 25 microgram is the best combination. Low safety is low, 25 microgram is the key. So tachysystole is low. It is contraindicated in scarred uterus, and as per the network meta-analysis, it is the most effective and safest strategy. Balloon plus oxytocin efficacy is good, safety is moderate, it is safe in scarred uterus, and it is an option for scarred uterus. So let's talk about the high yield points from this. So ARRIVE trial, as I've told you, IOL in 39 to 39 plus 4 weeks in low risk nulliparas, it decreases cesarean and decreases hypertensive disorders, but there was no difference in neonatal outcome. 84% of the induced patients require cervical ripening. Bishop score threshold 3 to 8 is used to define unfavorable cervix. Station uses a -3 to +3 scale. Now tachysystole definition, more than 5 contractions in 10 minutes averaged over 30-minute interval. Misoprostol and all prostaglandins are contraindicated in previous uterine scar. Scarred uterine option is balloon plus oxytocin only. Sublingual misoprostol is not recommended anymore despite higher bioavailability cause it causes increased tachysystole. Static oral misoprostol is better than titrated, same efficacy, fewer side effects, less cesarean section and less tachysystole. Oral misoprostol half-life is 20 to 40 minutes, so dose is more important than frequency. Vaginal dinoproston versus misoprostol. Misoprostol is more efficacious, less oxytocin augmentation. Dinoproston disadvantage is that it is expensive and needs refrigeration. Vaginal is better than intracervical dinoproston for cervical ripening. Best combination is single Foley's balloon 30 ml plus vaginal misoprostol 25 microgram, as it causes lowest cesarean section, highest vaginal delivery in 24 hours, least NICU and least tachysystole. Double balloon, single balloon is equal to single balloon in efficacy, more costly, no advantage. Digital Foley's insertion, speculum insertion only if there is failure or time, if you need less time. Better patient satisfaction, and digital Foley's is gives you better patient satisfaction. So balloon duration, no disadvantage in more than 6 hours placement. Balloon volume more than 30 ml, shorter time to delivery, 1.97 hours. 6 cesarean rates similar, more discomfort with larger volume. Applying tension to Foley's balloon, no effect on outcome. Outpatient ripening is conditional, safe in low risk, no monitoring is required, and best evidence for dinoproston or single balloon. Racial and ethnic disturbances in cervical ripening agents use none has been demonstrated. So key takeaway from this is that the best method is Foley's balloon plus vaginal misoprostol 25 microgram. All the other methods are recommended. Choice depends on clinical context, patient preference and uterine scar status. So thank you. This is all about the guideline, and I hope you have understood this guideline, and let me know if there is any particular guideline that you would like me to explain. This is one of the recent guidelines, so it may come in the exams, in the recent exams, and it's a good guideline as well, because now it's telling you that earlier we were so scared to use misoprostol, but now it's talking so much about using oral and vaginal misoprostol, and it also tells you that sublingual misoprostol should not be used, which we do in a lot of Indian practices. It is still done. Sublingual misoprostol is still given, but according to this guideline, sublingual misoprostol should not be used. So thank you. I'll see you in the next class.